Welcome, folks. We will begin in just a moment. We'll wait another couple of moments for everyone else to have the opportunity to join in as we have folks joining in, and we will get started very shortly. So good afternoon and good morning to wherever you might be today. And let me first start by welcoming all our participants. Thank you for joining today's discussion. My name is Dr. Rahul Gupta. I'm the Chief Medical Officer and Interim Chief Science Officer, SVP at March Dimes. We want to welcome you, and let me first thank our co-host of today's briefing, the Maternal Health Leadership Alliance. I would also like to go ahead and thank our co-sponsors. So we thank Sage Therapeutics and our partners, 2020 Moms, Postpartum Support International, and Equitable Maternal Health Coalition. I would also like to extend a special thanks to the Black Maternal Health Caucus, the Congressional Mental Health Caucus, and Congressional Caucus on Maternity Care. As we welcome you today, this panel discussion with a very special group of panelists could not be more timely following Mental Health Awareness Month as we grapple with how to better address the serious mental health challenges faced by women both during and after pregnancy. You know, it's a fact that, as you see listed here, 1 in 5 women are affected by anxiety, depression, and other maternal mental health conditions during pregnancy or the year following pregnancy. These illnesses are the most common complication of pregnancy and childbirth, and they impact over 800,000 women in the United States each year. Recently, the Centers for Disease Control and Prevention, the CDC research has shown that about 1 in 8 women experience symptoms of postpartum depression. Additionally, by the rate of depression at delivery is increasing and was about 7 times higher in 2015 than in 2000. So sadly, maternal mental health conditions often go undiagnosed and untreated. Therefore, they increase the risk of multi-generational long-term negative impacts on the mother's and the child's physical, emotional, and developmental health. It also increases the risk of poor health outcomes for both the mom and the baby. Perhaps of most concern, maternal depression can lead to suicide. In fact, recent studies have shown that suicide and overdose combined are the leading causes of death for women in the first year following pregnancy that is entirely preventable. Healthcare providers are missing opportunities to screen women for depression and other maternal mental health conditions, which, if left untreated, can affect a mom's health and can cause sleeping, eating, and often behavioral problems, not just for the person, but also the baby. In short, we need to do more to screen, to diagnose, and to treat women for mental health conditions, and throughout their pregnancy experience. So then the question comes up, about access. We know that access to mental health care is critical to the overall health of both moms and babies. The pandemic has certainly created a significant stress and anxiety for pregnant people, new mothers, who now have a number of new worries about their newborn, about their pregnancy, and about the delivery experiences. In the current climate with a pandemic, it could even be more difficult to access appropriate mental health care. We have made a lot of progress, but also are requesting increased funding to HRSA's screening and treatment for maternal depression and related disorders treatment program, and the new maternal mental health hotline. March to Dime supports measures to help identify and treat maternal mental health disorders, including universal screening and treatment, education, and surveillance. We're supportive of the Moms Matter Act that you will hear a little bit more about today, which establishes the Maternal Mental and Behavioral Task Force to improve maternal and behavioral health outcomes for women throughout pregnancy and, of course, up to postpartum. We've also built significantly on recent provisions enacted under the American Rescue Plan Act to extend Medicaid coverage to 12 months postpartum, which includes an additional option for states to extend the postpartum coverage from 60 days to 12 months. It's a significant improvement, but one that we need to continue to build on. So it's very important as we move forward on this progress that we look at, where the leaders are. And therefore, I have a special pleasure of introducing, we have a special message from Representative Lisa Blunt Rochester. Let me just say that Representative Lisa Blunt Rochester represents Delaware in the U.S. House of Representatives and serves as an assistant whip for House leadership. She sits on the House Committee on Energy and Commerce. The committee has broad jurisdiction over healthcare, the environment, commerce and trade, energy policy, telecommunications, manufacturing, and consumer protection. In this role, she's been an active health policymaker and a leader on maternal mental health issues. I also want to today acknowledge the leadership of Senator Kirsten Gillibrand, who has introduced the Senate version of the Moms Matter Act. Both Representative Blunt Rochester and Senator Gillibrand's leadership has been instrumental on the need to better address maternal mental health, and we thank them for championing this critical legislation in the House and the Senate. So at this time, I'd like to go ahead and start with playing a short message from Representative Lisa Blunt Rochester.
Greetings, and thank you to the Maternal Mental Health Leadership Alliance, the March of Dimes, and Sage Therapeutics for the invitation and for making this important event possible. I'd also like to thank the fantastic panelists joining us today and one of my partners on this bill, Senator Kirsten Gillibrand. The important compilation of bills known as the Momnibus is critical for our nation's mothers, and I am so pleased that the Moms Matter Act, in particular, is getting well-deserved attention. Living through a pandemic for over a year has illuminated racial disparities that long existed and made it impossible to ignore them. We are facing a maternal mortality crisis in America. We know that women of color are much more likely to have complications from childbirth. We also know it doesn't discriminate based on class, as we have witnessed some of the most powerful women in the world, Beyonce and Serena Williams, struggle with serious pregnancy complications. I'm proud to be a member of the Black Maternal Health Caucus, which was founded by my friends Representatives Alma Adams and Lauren Underwood back in 2019. and support the efforts of my friend, Representative Robin Kelly, Vice Chair of Energy and Commerce. The caucus itself was formed because we knew that we needed to do something to address maternal mortality rates in the United States, worst in the developed world, especially for Black mothers.
You can take it with you if you want.
The formation of the caucus led to the first of its kind, Momnibus, in the 116th Congress, a comprehensive package of 9 bills that would make investments in the social determinants of health that influence maternal health outcomes, fund community-based organizations devoted to improving maternal health for Black women, grow and diversify the prenatal workforce, and improve data collection. This Congress, we reintroduced the Momnibus, and I am proud to be an original co-sponsor of this package that addresses every dimension of the maternal health crisis. The bipartisan Moms Matter Act, which I introduced with Congressman John Katko of New York, ensures that we get the resources we need to mothers to help address mental and behavioral health needs. I was proud to partner with Senator Kirsten Gillibrand to make this bill not only bipartisan, but bicameral. This legislation would establish a grant program to address maternal mental health conditions and substance use disorders, with a focus on pregnant and postpartum persons from communities of color, and will grow and diversify the maternal mental health and behavioral workforce. According to the American Psychological Association, new mothers of color have rates of postpartum depression at close to 38%, compared to the 13 to 19% for all new mothers. Because of racial disparities in both screening and treatment of services, it is estimated that up to 60% of women of color do not receive any of those critically needed services. One of the key causes behind these disparities is a lack of access to providers who look like them. This legislation would change that and help save mothers' lives. Maternal mental health challenges are the #1 pregnancy complication, and we need to provide these mothers with the care that they need and the care that they deserve. In the wake of COVID-19 especially, we need to be ensuring that mothers can receive quality, culturally competent care as we see higher levels of anxiety and depression and overdose deaths across all sectors of society. We need to focus on providing the best health care for mothers, for their babies, for their bodies, and for their minds. Thank you again for having me and for creating a space to discuss this critically important topic. And thank you all for all of the work that you do and for your leadership.
Thank you, Representative Blunt-Rochester. We appreciate it. Moms do matter. Because moms do matter, it's really important for us to think about, before we get to the panel, so why this is important. So before we begin our distinguished panel, I would like to turn the podium over to Jamie Zalloway Belcedo, my colleague from the Maternal Mental Health Leadership Alliance. Maternal Health Leadership Alliance is really important. She serves as the Federal Policy Director and founder for providing us a little bit of remarks behind this beautiful memorial quilt that you see from Postpartum Support International. So Jamie, I turn it over to you.
Dr. Gupta, thank you so much. Thrilled to have you here for our second congressional briefing. The subject matter, as Dr. Gupta stated, is so timely. We are really thrilled to be able to uplift the Moms Matter Act, which is the mental health piece of the maternal mental health package, the Momnibus. And it is time to take a moment to take a look at some of these names that are on this quilt here, and think about what this memory quilt that Postpartum Support International has shared with us today. This is actually one of 2 quilts, what this symbolizes. And this is the reason why we're here today, is one more mom that passes away from something that is temporary, preventable, and treatable. is something that we really need to make sure that we are not allowing to happen in this country ever again. So taking a look just at this slide, I'm going to use the words that were given to me today by the founder of PSI, Executive Director Wendy Davis. Reading about the women behind the embroidered names is difficult. They are our sisters, daughters, our friends, and for many, they are us. But for whatever it was that put us on a road toward survival, we have hope that fewer women in the future will die, thanks to the great efforts of PSI, its sister organizations, and all those who devote so much time to make certain that we know that we are not alone and that we survive. And that's why we're here today. During our briefing, we will be speaking about the suicide aspects of maternal mortality as well as racial disparities. And I thank everyone for joining today, and I will turn it back over to Dr. Gupta. Thank you.
Thank you, Jamie, for such sobering words. You know, it's mental health is never easy, but when it happens during the course of pregnancy, it's especially difficult to bear, and the consequences are terrible oftentimes. So it's very important, and thank you for bringing us and humbling us. I want to introduce our distinguished panel today, which features some of the best and the brightest across the nation. We have Dr. Nicole Brathwaite, we have Dr. Lena Mittal, and Dr. Mary Kimmel. And they will bring today for us a wealth of knowledge and clinical experience from innovative approaches in treating maternal mental health to the discussion. What I'll do is I'll go ahead and start with introducing each speaker at a time, and please continue to put in chat box your introductions. We have a significant number of folks in the audience that would love to hear from you. So also, if you have questions, please feel free to provide us questions that we have time answer at the end. So let me first begin in this fantastic panel by introducing Dr. Nicole Brathwaite. She's a board certified child, adolescent, and adult psychiatrist. She's the founder and CEO of Well Mind Psychiatry and Consulting Company. She also serves as the vice president, medical director for at-home and scheduled care at Array Behavioral Care, which is leading the largest telepsychiatry services provider in the United States. She's a member of the board of directors for New England Council of Child and Adolescent Psychiatry and Families for Depression Awareness. She's also nationally recognized as an expert in trauma, the impact of racism on mental health, developing trauma-informed schools and organizations, implicit bias, postpartum mental health, and mental health in communities of color. So I want to welcome you to this panel today, Dr. Brathwaite, and we can't wait to hear from you. So turn it over the podium to you.
Thank you so much. Good afternoon, everyone. Thank you for joining us. We certainly recognize plenty of people have Zoom fatigue, so we do not take it for granted that you are here and recognize the importance of this conversation. Briefly, I am just going to discuss both my experience as a woman who's gone through postpartum depression and as a psychiatrist who supports and treats women who are dealing with perinatal and postpartum mental health issues. Next slide, please. As Representative Blunt-Rochester mentioned, about 20% of women display some symptoms of perinatal mood or anxiety disorders. However, when we're thinking about African-American or Black women, that number more than doubles. So 44% of African-American or Black women experience anxiety, depression, OCD during pregnancy. And there was actually a study out of New Jersey where they looked at about 3 years worth of Medicaid claims, and they found that white women were nearly twice as likely to receive treatment as were women of color. And despite the fact that a disproportionate number of Black and Latino women are suffering from postpartum depression, they're not receiving the support or the services. And overall, in general, rates of mental illness do not vastly differ amongst ethnicities, but the severity of symptoms differ because of the lower rates of treatment, lower rates of screening, and less access. And frankly, suicide is a significant risk factor for untreated perinatal mood or anxiety disorders. African-American women are at greater risk of dying from medical complications. but we're also at a significant risk of dying from suicide secondary to postpartum depression. And this is something that is really interesting and very personal for me, but I think when we often think about money, we kind of assume that the more money you make, the higher the degree you have, the more protective it is. But that's not the case. And although socioeconomic status may be for many groups conceptualized as a health protective factor, that is not the case, particularly for African American and Latino women. And actually, studies have shown that Black women who make more money or are middle or upper income and live in predominantly white settings have actually been shown to have higher rates of suicide. And having a higher degree is actually a risk factor. So Black women who have advanced degrees had the worst pregnancy outcomes amongst all groups. And in fact, a Black woman with an advanced degree is more likely to lose her baby than a white woman with a less than 8th grade education. And again, this is personal for me. So this picture is day 2 of my oldest son's life, Aiden. He was the yummiest 10-pound, like chubby baby of goo. And in this picture, I was ecstatic. We struggled with infertility. We had pregnancy losses prior to Aiden. And I wasn't even sure if I could have children. And magically and miraculously, Aiden appeared, and I was so happy. However, I wasn't prepared for the aftermath, for experiencing postpartum depression. No one educated me about it. And I was a psychiatrist. I had just finished my child training. I was a full-blown psychiatrist, a physician. I was educated, but no one told me about postpartum depression and no one screened me for it. So about 3 months postpartum, I was experiencing increasing symptoms of sadness and hopelessness and questioning my ability to mother. And I'll never forget, I was driving to work. I had just returned to work after maternity leave. And in that moment, postpartum depression had me convinced that I was not a good mother, that my child and my husband would be better off without me. And I had multiple visits with my OB and visits with the pediatrician, but no one had asked me about it. And looking back, it was clear that I was struggling in a variety of ways. And I remember driving to work in a split second, I had the thought that, you know what, this is too much. They're better off without me. I'm a terrible mother. And I literally in my head had a plan to drive my car into a median. And when I think back, it doesn't even feel like it was me. Like I honestly don't even recognize who that person was. It was like the postpartum depression literally took over. And in that moment, someone called me and kind of snapped me out of it. And I remember returning home and telling my husband, I need help. Something is wrong. And he's like, absolutely, let's pray about it. We'll get additional supports from family. And I said, yes, let's pray. And then when we're done praying, I need to call my doctor. I need someone to come and cook and clean for me. I need you to take more nights, and not just for this week, for a very long time. But I'm realizing that that's not something that I should have had to figure out on my own. This was something that should have been screened for, should have been asked about. Next slide, please. And so when we're thinking about these disparities, again, COVID has, not even a flashlight. It's like a spotlight on all of the disparities in medicine. And frankly, disparities exist in medicine for nearly every major medical illness. And certainly pregnancy is no exception. Black women are at a significantly greater risk of having complications. They're at greater risk of dying. Some studies have even shown that Black women are 243% more likely to die during or after pregnancy. Many of these illnesses and concerns could have been prevented. Preeclampsia is more common. And not only that, Black infants are more than twice as likely to die than white infants. Next slide, please. And so when we're thinking about why do these disparities exist? Why in some states are the rates of maternal death equal to that of third world countries? And the risk factors are multifaceted. Number one is racism. I mean, we just sometimes just have to state it. I know that can sometimes be a hard word for us to really deal with, but we also have to recognize that racism exists in many forms. It can be structural, societal racism, institutional racism, or even individual racism. And as an African-American individual who's pregnant or postpartum, you essentially can run into racism in basically every single area of your life with every single physician or clinician that you engage with. It is important to understand that racism in every form, whether it's overt, like a racial slur, or more covert, like microaggressions or implicit bias, all of those experiences are traumatic. Racial trauma is real and very much mimics the effects of other forms of trauma and can produce PTSD-like symptoms. Trauma is cumulative. The more trauma you experience, the greater the risk of experiencing numerous chronic diseases later in life, like obesity, diabetes, hypertension, substance use, mental illness. And these comorbidities put African-American women at greater risk for experiencing complications in pregnancy. Not to mention also, our pain is often dismissed by individuals in the medical field. We're not screened. Again, you know, I was a psychiatrist. I have an incredible OBGYN, and she never asked me about my symptoms. And I almost lost my life because postpartum depression went on for so long without being treated. Other risk factors include toxic stress. And toxic stress is essentially the stress that it outpaces our ability to cope. And again, racism is a form of toxic stress. Poverty is a form of toxic stress. And being an African-American woman, potentially living in an impoverished area, or even working in an environment where you're one of the only people and you are constantly battling microaggressions, it stresses your body, it stresses your system. And if you're pregnant, it also stresses the baby. Other risk factors, of course, family history of mental illness, a personal history of mental illness. In my case, prior losses, having a traumatic birth. Again, my son was 10 pounds of yummy deliciousness, but oh my goodness, giving birth to a 10-pound baby was a challenge. And it was certainly a traumatic birth. And so I had all these risk factors that should have raised red flags, and it didn't. Next slide, please. And so now what? What can we do to address this? And I realize this is a very short conversation and a short snapshot, but there are things that we can do now. As a family member or a friend, there are four things I recommend that you do. Number one, advocate. So talk to your partner, talk to your family member ahead of time. What are their wishes? What do they want? I remember I had a 2-page double-spaced type birth plan for my first child. And I showed my OB and she's like, that's very nice, but that's probably not going to all happen. But I did share it with my husband because it is important that someone speak for me if I can't speak for myself. Number two, educate yourselves. Know the difference between baby blues and postpartum depression. Understand what is considered an emergency postpartum. If someone is experiencing psychotic symptoms or seeing or hearing things, that is an emergency. So as a family member or friend, making sure that you understand what to look for. Listen, as moms, we often have a hard time asking for help. We need help. If a mom is tired or if she's complaining about having to make a meal or do laundry, step up, do that for her. These are easy things that we can do to help remove some of the stress. And then lastly, be the village. Children were never meant to be raised or born in isolation. We need our family. We need our friends to step in and support us. Certainly additional supports, having payments and insurance cover midwives, doulas, and family members in the room. Screening every single pregnant person that walks into or out of your office for perinatal mood or anxiety disorders, and having that be a universal requirement. Certainly educating clinicians about cultural sensitivity. For example, women of color, we don't often present with complaints of depression. We may present with, my head hurts, my back hurts, I'm exhausted, I feel pain all over. If you are not culturally aware or sensitive, you may miss those signs and then not screen for other mental health issues because you don't recognize that somatic symptoms or physical symptoms are very common complaints in women of color. And then we need to deal with racism. We need to deal with racism in training, in hospitals, with nursing staff, in hospitals. At every level where racism exists, we have to be willing to fight it and address it, because just teaching people individually how to address bias is not enough when they exist in a system that was literally built on racist principles. And so we have to be willing to become uncomfortable, frankly, be comfortable being uncomfortable and addressing our biases. Next slide, please. And these are my two little adorable monsters, Aiden and Kyle. So thank you again so much for having me.
Thank you, Nicole, and thank you for sharing both your professional, as well as your personal story, because this is, I know, for so many of us tuned in today, is so powerful to not just hear it from you as a provider, but also as someone who's gone through this personally, and the data speaks for itself. The numbers speak for themselves. We do not have to. No longer have to tolerate the data that we see and you've shared. Thank you. And we must do all we can to change it. Let me move also to our next panelist. So Dr. Lena Mittal is the Chief of Division of Women's Mental Health at Brigham and Women's Hospital and an instructor in psychiatry at Harvard Medical School. She's a program director for the Women's Mental Health Fellowship at the Brigham. Also serves as Associate Medical Director for Massachusetts Child Psychiatry Access Program for Moms, or MCPAP for Moms, which is an innovative statewide consultation service for providers seeing pregnant and postpartum women with mental health and substance use conditions. Dr. Mittal is also board certified in psychiatry, psychosomatic medicine, and addiction medicine. Welcome to you, and I will turn it over the floor to you, Dr. Mittal.
Thank you so much, Dr. Gupta. You can advance my slides. It is so important to be thinking about the way maternal mental health can have complex impacts on an individual, her child, and family. And I could not have stated any of this any better than my colleague, Dr. Christian Brathwaite. And so what you've really heard are the ways in which mental health can have wide and far-reaching impacts. My particular area of interest is around mental health in pregnancy and in the postpartum period, with a special interest in substance use. And this is often, I think of as sort of the hot potato of healthcare, where we see families, children who are impacted by the complex issues described, but also falling between the gaps of expertise in healthcare providers. And so I find that maybe I lean into complexity a little bit more than the average person, but this need really is, it highlights where we can collaborate and we need to think about increasing access. Next slide. And that's where perinatal psychiatric access programs come in. So I am the Associate Medical Director for MCPAP for Moms, which is the first of its kind, but not the last, for perinatal psychiatric access programs. We provide capacity building education for frontline providers who are working with perinatal individuals. Across the Commonwealth of Massachusetts, we do educational programming, we create educational materials, we run an 855 line, which provides real-time telephonic and patient-to-provider consultation, and we do resource and referral finding as well. Next slide. So MCPAP for Moms, as we call it, it's a statewide program that was really born out of this concept of perinatal psychiatric access programs that were originally created to leverage a very small amount of expertise for child psychiatry in a large population. And so that's where the Massachusetts Child Psychiatry Access Program, MCPAP, came from in 2004. And in the context of recognizing that there was a dearth of perinatal psychiatry expertise in our Commonwealth, the Postpartum Depression Act was passed in Massachusetts, and from that formed an offshoot of the MCPAP program called MCPAP for Moms, which really helped to leverage the small number of perinatal psychiatric experts in our state to address the large population of birthing individuals. After we launched in 2014, we were originally focused largely on perinatal depression, but as we all know, depression is just one component of mental health and mental health disorders, and we began to broaden our focus and broaden the umbrella that we use to define mental health and wellness. And over time, we worked with our legislators, we worked with advocates, we worked with many of the people on this panel today to really engage and broaden our scope. And so so we advocated for increased funding, and we expanded to include substance use disorders in our definition of mental health and mental health conditions that we can work to consult on. And to date, we have served nearly 9,000 birthing individuals in the state of Massachusetts, and we continue to provide consultation. Next slide. We are primarily a resource for providers, where we really have this focus on capacity building, but we're also a resource for patients and families. And so this is our website. You can take a look at some of the materials we've developed. They're widely and publicly available, and we are available to providers to call us at any time during business hours, and we work our hardest to be flexible and provide real-time, flexible consultation. Next slide. So who can call us? Our perinatal psychiatric access program is designed, our primary consulting providers are prenatal care providers. So obstetric providers and midwives call. About 40% of our consultations are for this provider group. The next most common type of caller are psychiatric prescribers, and then primary care providers, pediatric providers who are increasingly important in engaging families around mental health needs and screening throughout the lifespan, and family medicine providers are our next most common. And recently, with this expansion in funding and really drawing in and understanding the importance of the intersection of mental health and substance use, we've also really been working to engage substance use treatment providers as well as our newest provider group. Next slide. And as my colleagues on this panel have already really well described, mental health conditions are a leading cause of pregnancy-related deaths, and most importantly, preventable pregnancy-related deaths. And when we think about the mental health conditions that contribute to this rate of mortality, we're thinking about suicide, we're thinking about overdose. And within overdose, we're thinking about intentional and unintentional overdose, which can be impacted by substance use disorder and the confluence of mental health and substance use. And within those substance use conditions, most commonly we're seeing opioids at least as a contributor, if not the primary substance of use. Next slide. For a little bit of background, opioid use disorders in pregnancy are treated pharmacologically, meaning with medications, with methadone and buprenorphine primarily as first-line treatment. And these medications can reduce overdose-related deaths, but they can have wide-reaching health benefits for both the pregnant individual and also the fetus. Next slide. And what I'd like to really think about is to dig in a little bit into how opioid overdose in particular can really drive this maternal mortality rate. So these data are from my colleagues at the Massachusetts Department of Public Health, who have done immense work in really understanding and bringing together a wide variety of information across multiple databases. This was years of work that really came together and helped to paint this picture that the risk of overdose in the context of pregnancy fluctuates. And so someone who has an opioid use disorder is at quite high risk prior to pregnancy for death related to opioid overdose. But actually during pregnancy, the risk goes down. Women who are pregnant are increasingly engaged and motivated to engage in health-related behaviors and in treatment. And then the risk continues to rise as the postpartum period continues. And the risk actually escalates in the 6 to 12 months postpartum. So this is after obstetric care is usually over, and in this time of significant psychosocial challenge and transitions in care, where the complexity of families, it really increases. And in fact, in that 6 to 12 months postpartum, the rates of overdose death are actually higher than they are pre-pregnancy. But if you look at the bottom part of this image that I've put up here in the orange bars, what we see is women who are treated with medication, who are on pharmacotherapy, again, those medications I mentioned before, methadone and buprenorphine, they have significantly lower rates of mortality. And what this points to is the opportunity here that we as treaters can save lives by providing these life-saving treatments. Next slide. Now, when we talk about mortality related to opioid overdose, those who've come before me have really described well that we are not talking about this risk applying equally across all populations, but in fact, in our communities of color, in Black males and females, we're seeing increasing rates of opioid overdose leading to mortality and driving our mortality rates up in both men and women. Next slide. And when we think about perinatal individuals in particular, again, we have emerging and clear data that racial inequity in mental health screening and in prevalence rates is clear related to perinatal mood and anxiety disorders. But the concept of screening for substance use disorders is a relatively newer recommendation from our professional societies. And we are still needing to learn about whether these racial inequities are seen in perinatal individuals with substance use disorder. But given all of the structural challenges and all of the structural racism that have been described by my colleagues thus far, it would be hard to imagine that those inequities are not there. But there's still much more work and research to be done. Next slide. Now, one piece of data that's really emerged in the context of racial inequity, though, is that amongst women of color who are identified to have opioid use disorder, there are clear inequities in the likelihood of receiving treatment with medication at all. And I've described that, in fact, these medications are life-saving. And women of color are much more likely to receive methadone than buprenorphine, which is also a really interesting difference, because buprenorphine is actually a medication that can significantly reduce the risk for overdose death. And so if we're seeing these inequities in available treatment and access to treatment and engagement in treatment, then we have to be thinking that this must be an important contributor to risk of death. Next slide. So for me, this population of women who have both mental health and substance use needs during pregnancy, while there are so many challenges that we as providers face in working with these families, these are illnesses that are hard to treat, that have relatively challenging legal issues that may impact the treatment, that come with, the patients that we see come having experienced significant trauma within the medical system and within their lives and within their communities, and the complexity of multiple diagnoses. And then we as providers have to face and reckon with the fact that we carry biases, and that our healthcare system also is biased, and we have to recognize how challenging it is for our patients and clients. And then furthermore, we think about access to expert medical care, especially care amongst providers who feel comfortable in that middle space between substance use, mental health, and pregnancy care. There are so many challenges, but at the same time, there is so much opportunity. Next slide. And MCPAP for Moms, as an example of a perinatal psychiatric access program, is really designed to help promote maternal and child health in the context of building capacity for frontline providers to address these complex needs and to enhance education and provider-based expertise, collaboration, and access to care. So thank you so much for your attention to this important issue, and thank you for inviting me to participate.
Thank you, Lena. And clearly in the chat box, you can see some really valuable links as well, and encourage you to check those out as well. So we thank you, and the message is loud and clear, which is a lot of these unfortunate events, including the mortality, but also morbidity and the challenges that happen, disproportionate impact does not have to happen. So with that, I'm going to move to our next panelist, Dr. Mary Kimmel. Dr. Kimmel specializes in treating women during pregnancy and postpartum period for mood and anxiety disorders. She's the co-director of UNC's perinatal psychiatry program, as well as the medical director for North Carolina's maternal mental health matters program, which obviously is a collaboration between the Department of Health as well as Duke. So welcome, Dr. Kimmel, and I'll turn the podium over to you.
Okay. Thank you so much for including me. I'm really honored to be included with this panel and to be here to speak for the individuals that I work with and their families, both on the patients and the colleagues side, and also to be here to speak as a mom myself. Next slide. So when we talk about perinatal, we often think about postpartum depression, but I really like this term perinatal mood and anxiety disorders, which is a mouthful. And a lot of the women I work with prefer to say PMADS. And I think people like this term because every woman has her own unique mix of different symptoms, and that this really is an umbrella term that encompasses the different experiences of different women that can range from depression, so kind of not enjoying things, to, you know, women who don't really feel they understand depression because they say, well, I don't feel depressed. I just am so worried. And I'm so worried to the point that I can't go to sleep at night. I'm standing, you know, waiting in the baby's room, trying to keep an eye on the baby. We have women who have increases in sort of intrusive thoughts about something bad happening to themselves or the baby, or even them doing something, and sort of an intrusive thought. We have trauma, and I think this is something we haven't even really begun to fully understand. I mean, Dr. Christian Braithwaite did such an amazing job talking about that. And there is so much birth trauma, and it absolutely, we have, you know, I've worked with women where that was a beginning point, that they had to go through all of this stress of a very, you know, and that is a very critical point where they needed more support. We see actually in the perinatal period that there is a higher mix of bipolar disorder symptoms. And in fact, some of that may be what we need. I mean, you really do have to, you know, to be up with the baby every 2 hours, to like be getting, you know, getting all those diapers and, you know, onesies and cleaning the onesies and all of that. You almost need an increase of activity. And so that can then become kind of, you know, can get turned on for some women. And then finally, postpartum psychosis, which actually is a form of, really the way I think of it, as also an umbrella term that includes a number of different experiences, but often those experiences are mood and anxiety related. But I also wanted you to think about, so here, this is actually something that from our NC Matters program, Karen Saxer is a midwife that works with us and designed this. And I love this because it really shows that mental health is something that we all have needs for at different points in this process. And that at each point, there are unique needs. And you think about, for example, the 20-week ultrasound. I mean, there is so much emotion mixed up with even that experience, and women needing support and being with them in whatever they are going through and their unique experience. And then I think one thing that is missing from this slide is actually the other people. So, and there was a great question about actually the rates of postpartum depression in dads. And this is also something that we're beginning to understand. I have statistics that actually 50% of dads whose partners are going through postpartum depression, that they also go through depression. They go through it in a unique way that's also not often recognized. But also, I think this is an area, and we have people like Sheehan Fisher at Northwestern who are looking into this, but this is also a gap, is really understanding how does this affect families, and how do we meet the needs of birth and non-birth parents? And of course, them as a triad. I mean, I love the dyad, but I think we should maybe be thinking even more about that being a larger, and maybe it's not, maybe it's a cool, you know, a quad, I don't know. So thinking about that. Next slide. So this is from our NC Matters program, which is actually modeled after MCPAP for Moms. In fact, when I was so excited learning about the MCPAP for Moms program, and I thought North Carolina needs this. How can we do this? And then with the HRSA funding, we were able to. And so those, I show this to show, so those hearts actually cover the counties that we now have received calls from. So these are providers in counties who have reached out to us for support. But I also want to think about the counties where there are not hearts yet. And I think part of this process, you know, we have gone out and we've talked with practices. We're trying to understand their screening practices. Dr. Mattel did such a good job talking about substance use and how do we meet that need? I would also add, how do we screen for anxiety, and I showed you this, you know, this umbrella term of all these different experiences that women are having. How do we help providers, you know, OBs, midwives, pediatricians, how do we help them screen for all of those different experiences in short, you know, visits, and do all the other things they have to do in their visits? And so I think we need data to be able to understand who are we screening. And it's actually, I think what I've learned from this process, it's harder to get good data than I think I thought. But we need data, and we need to understand who's getting screened, where can we improve? Not that we're saying people are not doing what they need to, but instead, where can we continue to improve and continue to improve access? And also, so we really believe this is important too, to make sure that we're meeting the needs of those women those families that may not have access otherwise, people who are underinsured and non-insured. And as Dr. Mattel was talking about, that postpartum period, that is a complex period. Many women lose their Medicaid actually. And so then we're trying to figure out, how do we meet their mental health needs from that kind of, 3 months to a year, when it's still this critical time, but they're not able to access care. Next slide. So now we're going to switch gears to another. So I've showed you one solution. So, talked about how we have adapted MCPAP for moms to meet the needs of North Carolinians. But now I want to talk about another solution. And so this is actually pictures of mother-baby units, and those are actually mother-baby units specifically for PMADs. So units that are geared specifically for women going through, for example, postpartum depression, so they can be on the unit. They can be hospitalized as they need that kind of level, if they need that kind of level of care, but they can also have their baby with them. And I think what's amazing to note is you look at the UK, which is about half the size geographically of California. It is about, and it has, it does have about 60 million people, but you look at that and they actually here have 21 mother-baby units. And those units range from 4 to 13 beds with an average of 8 beds. And they actually, when I meet with colleagues from the UK, they talk about how they want more mother-baby units. And so this really is a focus on how we need to focus on the needs of the parent and the child, and as that triad, and how do we meet those needs, and how do we have the services that really are with them in this process, and also provide the medical care, because these are also medical conditions. Perinatal obsessive compulsive disorder is a medical condition. Postpartum psychosis, particularly when you've seen a woman going through it, you fully understand it is a treatable medical condition, but it is a medical condition that needs treatment. Next slide. So so Dr. Samantha Meltzer-Brody, working with the support of the chair at the time, Dr. David Rubinow, and with a great support team, as you can see listed in this article, as well as the support of actually UNC's administration. We were able to open a mother unit, a perinatal psychiatry unit. So the babies don't stay on the unit. We're still figuring that one out in the United States. But we are able to have moms come into a specialized unit developed to their needs. And you'll see here kind of the spectrum of different things that women come in and get support around. And we have OT that does very targeted things around helping mom think about, how does she fit self-care now in that and how does she make sure she's getting her needs while meeting the needs of her family. We have RT that works on things like helping kind of with the dysregulation that can happen with the amount of stress that you have gone through, and helping you find ways to calm your system again. And I really want to highlight that number down there of so almost 87% of our women on the unit have had suicidal ideation. And we have women who come, so we have women, what's always amazed me is actually the number of women with, for example, postpartum psychosis, which we think of as a rare thing, and yet the number of women we see, even from our area right around us in the triangle, the large number. And as Dr. Christian Braithwaite so elegantly talked about her story, the near misses. The stories of women who come in, and the stories of how they just, that phone call that made a difference, that was that tiny switch that got them in. And I think about all the women who didn't have that transition point and that were missing. And then I will also say, we have women that come from all over the country to come to to utilize our service. We had a woman just come from Alaska. So we have women come from all over. And so women, their families, they do want this. And this is something they know they need support. And so let's look at the next slide. And I'm happy to say that, it hasn't stopped with UNC being the first unit. There are two other units that do inpatient work. And then there is a growing number of programs that are doing mother-baby outpatient work, and also modeled after actually the program at Brown, at Mothers and Babies programs. And so also kind of this focus on, and I think what we can take from this is that people really need support around the dyad and around the triad and the quad. And so how do we, really, how do we support this group and have services that really, there are additional services that are needed. And so that's growing, but I also want you to look and see, this is clearly pockets. There are many pockets in our country that are not getting these services, and people have to travel from places like Alaska. Next slide. And then finally, I want to finish up with actually this really amazing writing from Ariane Audet. So she was actually a patient on the perinatal psychiatry inpatient unit. She's a photojournalist. And I think this really sums up the experience of many women. So I'm very appreciative that she wrote about this. Actually recently was published in Today's Parent. She said, the following week, the intrusive thoughts came rushing about more frequently and more violently. My therapist and I tried different coping mechanisms, but the thoughts wouldn't leave me alone. And no matter how many walks outside or deep breathing exercises I did, my brain kept telling me I should kill myself. I drove the 5 hours that separate my house in Virginia to UNC, sobbing uncontrollably every mile of the way. But when they disappeared behind the heavy steel door of the psychiatry unit that evening, I felt I could breathe again. Professionals were in charge and I would be okay. And so we need to make sure that more women have access to that, knowing they're going to be okay. Then the last slide, please. So this is actually work of Ariane Audet. This is part of her photojournalism. So she goes around meeting moms all over and telling their stories of postpartum, because each mom has their own unique experience. And we all need to celebrate those different experiences. Thank you.
Well, thank you so much, Marianne. And clearly, this has been really an important discussion today. And before we close out, it's very important we know what to do, what's next. So for that purpose, I'm going to turn it over to my co-host to both discuss policy actions as well as close out. Jamie Zalway-Belcito, I'll turn it over from the Maternal Health Leadership Alliance.
So thankful, Dr. Gupta, Dr. Kimmel, Dr. Mittal, Dr. Christian Brathwaite. Everything we're saying here today, I feel as if we could have a 2-hour briefing, and unfortunately we're closing in on the top of the hour, and I'll try to be brief. I want to say, as a mom who experienced postpartum challenges in 2 different manifestations, Dr. Kimmel talked about that arc or that spectrum. We need to be doing a better job. And I want to say thank you specifically to Dr. Christian Brathwaite. The patient voice centers the conversation. And this voice has been finding ground over the past 6 years expressly with federal policy. And what we're finding out, the more and more data we have, the more this conversation begs to be had at all facets of maternal health. So thank you so much for the experts and my colleagues and everyone that I consider a dear friend doing this work here. I did want to say a few words as we take a look at these legislative priorities, and please take a look at these 4. I could have put more down, but 4 fit in the slide, as demonstrated in today's panel. The news, by the way, that state and federal policy initiatives are popping up in light of COVID, in hearing the incessant plea of the voices of families who have lost loved ones and those who have almost lost their own life. I put myself in that category as well. We are coming to terms with the reality that maternal mortality in this country has been growing for 2 decades. The CDC released a report in 2019 citing that 66% of maternal deaths in this country were preventable. American Indian, Alaska Native, and Black women are 2 to 3 times more likely to die of pregnancy-related causes than white women. This is unacceptable, and that's why we're here talking about this today. Postpartum, perinatal, maternal, postpartum maternal mental health. I'm getting all of my acronyms mixed up here. Issues are preventable, treatable, and temporary. And we need to do the work and work with those who take care of us, addressing the racial inequities and the ability to discuss these issues. I want to also put out here that women, according to the Mass General Hospital Center of Women's Mental Health, in June of 2020, women were less likely to be screened for PPD in the postpartum space if they were African American, Asian, or non-white. Lower rates of screening were also observed in those who were insured by Medicare, Medicaid, younger than 24, or were non-native English speaking. And I think that these are all areas we need to be very well aware of. I'm going to drop some information about Medicaid into the chat here. We need to follow suit, not just with the recommendation to expand Medicaid with option for the states. We need 12 months postpartum coverage. Everyone should deserve a healthy start, a healthy parent. And I want to put out here what Dr. Mitchell was saying. We see postpartum mental health challenges peak in the 6 to 12 month frame. And when we are taking a look that those who are on Medicaid, with 50+% of our births in this country are Medicaid, and the birthing parent loses coverage at 60 days, that's a fail. We need permanent, mandatory, and fully funded Medicaid by the federal government. We need to continue to fund the existing programs. The MCPAP for Moms program that we talked about today, along with the HRSA funded grant program in North Carolina. That's actually the basis of the HRSA MDRB program, and we need more money. COVID has shown, has blown the lid off of everything. It's blown the lid off that we need to support our pregnant and new birthing parents. We need more money to states. 30 states and provinces and territories applied for money, and only 7 received them. And that was before any of what we've experienced this past year went into play. We need additional monies for what's going to be a new maternal mental health hotline, 24/7, culturally appropriate support, public awareness. This is very exciting. We need more money. We need more money. Why? Because just like baseball and apple pie, we are the basis of this society. We need to take care of birthing parents and babies. This is the mental health component of a 12 bill Black Maternal Health Caucus Momnibus. This is the mental health portion of this. It's going to expand access and treatment and support for maternal mental health conditions. It's going to grow and diversify an already small, very difficult to access space in maternal mental health and behavioral health workforce. We need to be diversifying that workforce and growing it. And it invests in programs to support pregnant postpartum people with substance use challenges. This is part of the conversation we had in 2016 with the 21st Century Cures Act. We need to understand that this is continually part of this, and we've seen that substance use has gone up during COVID. The Momnibus. It is exactly what it is. It is the Momnibus to uplift us all. It is 12 bills that address the maternal health, maternal mortality crisis in this country. And it addresses so many areas: social determinants, racial and cultural bias, environmental stressors, women who are incarcerated. There's so many things to peel back here, but let us use our voices, use our platform. Get out there and champion this. For those who are representing their boss's office in Congress today, get your boss to sponsor HR 909-0484, or we will be looking to meet with you. The time is now. It is the CDC's #HearHer campaign, the continued amount of information that's going out there. The time is now. It's time to focus on the health and wellness of this country. And that begins with pregnant and postpartum birthing people. I am so thrilled for everyone's attendance today. I thank everyone for their expertise, this amazing panel. If anyone needs to get in touch with us, I hope you know where we are. We can advance that next slide. We will get in touch, any Q&A. And thank you again to our sponsors, our Congressional Caucus partners, and our partners in getting this area of maternal health escalated. I want to thank you to our moderator, Dr. Gupta, and everyone here today. I wish everyone well, stay cool, and let's keep marching forward on this issue. Have a great day.
Thank you, everyone. Thank you, Jamie.